Okay, well, I think we should get started. It's past the hour, the half hour. So thank you everybody for joining what is the first in our 2022 customer webinar series. The first topic being expanding out shared care record access. Brian, if you could perhaps go to the next slide. So I'm Katie Brooks, Senior Marketing Manager, and I'm joined today by my colleague Brian Murray, our UK and I Sales Director. Over the summer months, we'll be running 3 webinars for our customers. I will send the details following this session if you haven't yet signed up for those. So next month, we'll be looking at the topic of care planning, and August, we will be covering patient engagement. So 3 sessions to run over the next few months. Next slide, please. And these webinars, whilst hopefully useful in themselves in terms of providing some information on what shared care records are doing, what your peers are doing, other avenues you might want to explore with your own shared care record. The content is also a bit of a teaser for our UK and Ireland customer conference, which will be held on the 13th of September in Bristol, where we'll obviously have much more time across the whole day to discuss shared care record case studies from both the UK and abroad, the tools that you might be looking at adopting for population health management around care planning, virtual wards, patient engagement, analytics, medicines, and more. And we'll also be giving updates on things like national standards, work we're doing with PRSB, the technical side of your shared care record as well. And for those of you who haven't attended before, we'll also be joined by many of the product leadership team from Orion Health. So as well as connecting with your peers and having that networking opportunity with other NHS folk, there'll be a chance to meet face to face with many of the people who are designing Orion Health products, and your chance to you know, give them your feedback too. Then the day after the customer conference, we'll be running a customer advisory board meeting. So whereas the customer conference welcomes everybody from your shared care record who would find it useful to attend, the customer advisory board meeting is designed to be a smaller meeting to enable more interactive discussions. So we're inviting up to 2 people from your organisation to that, ideally from a programme or clinical background to best contribute to the agenda. So from that meeting, we'll be really looking to understand more about your market requirements, the roadmaps you have for your digital health strategy, and making sure that those are reflected and aligned with the development of our solutions here at Orion Health, and that we can support you as your long-term partner. So yes, after this meeting, I will circulate the links where you can register to those events. That's the intro from me. So I'll pass over to Brian to talk about today's webinar. Throughout the webinar, if you have any questions, please do use the chat functionality you'll see at the bottom of your screen to ask any questions, and we will put those to Brian at the end of the session. So Brian, over to you.
Thank you, Katie, and thanks for everyone for joining this week. It was me stuck on at an airport and in an aeroplane that meant we had to reschedule from last week, which is where I also think I caught COVID. So if I'm a bit breathless, it's because I'm still suffering at the moment, but we shall struggle on, as they say. So in this webinar, we wanted to touch on the subject of expanding out usage to the shared care record and just share some examples of other organizations doing that, where shared care records have done that, but also look at fundamentally why you might do something like that. There's 2 ways to look at this. Now, from the citizen's point of view, there's a duty of care to all citizens across an area. It's about equality and equity of care as well, so that where whenever somebody is being looked after, the people looking after them have access to the right information that they have. I hate the phrase right information at the right time for the right person. It's overused, but it really is very pertinent to hear, and we'll all have personal first-hand or second-hand stories of where the right information could have made a difference to somebody. From a citizen's point of view, the number one complaint that people always make, or the number one thing that always comes up, is having to repeat themselves over and over again. And we all know, depending on somebody's condition, whether it's their age, their mental health, or whatever it might be, repeating themselves is not only very annoying, but very often people don't like to share the information that they're having to repeat over and over again. And having the information in a digital format which is shared provides much more equality of care for the different people. In terms of the workforce, this is something that I always find very dear to my heart, because I'm not a clinician and I don't spend my time treating patients, but what I do has a direct result, a direct effect on how people can do their job. So care is delivered across so many different organizations in a real multidisciplinary way. It's important that people have that information. It makes life easier. And I've put it in inverted commas because it's a meism, the buggeration factors that people have on a daily basis trying to find information. Recent example, friend of mine who works in a care setting, and a patient had become disorientated and was becoming a little bit aggressive. And the patient was complaining that it was their medication that had been changed. And the care staff were able to find out an entire day afterwards, after making multiple phone calls and speaking to the GP, that the medication hadn't been changed at all. It was something else. And having that information available straight away would have made a massive difference. Big difference to the patient, but also the staff who are having to deal with situations that could be avoided, but also making multiple phone calls, looking through multiple files to get the information that they need. Just over there on the right hand side, I think this is an interesting slide that was supplied to me by Connecting Care, because normally on a slide like this we would have the organizations contributing data into the system, so a list of acute hospitals, the mental health trust, etc. But this actually illustrates all of the organizations that are accessing the information, not contributing to the shared care record, but actually accessing the information. And we have prison service, we have third-party organizations, we have charities, we have care homes, etc. And this is the sort of picture that we want to try and build for all our customers. I found this slide online, and I really like it, and it won't be a surprise to anybody on the call to see something like this. And what it illustrates is how care is provided by so many different organizations, but within a diagram like this, and within your own shared care records as well, there will be centers of gravity around this, whether it's the GP practice, the acute community and mental health trusts, which are contributing data and the main people who currently have access to the information. But patients move around a huge ecosystem. The colors of the lines and the width of the line mean is how many times people are referred and how many number of people are referred across this. But the key here is that it is a real spider diagram. It is care delivered across all these different organizations, and why shouldn't people have access to the information they need to be able to treat the patient in this way? Because all of these are points of referral, all of these are points where things can be missed, and all of these are points of buggeration factor, but also points where the patients very often end up repeating themselves. This roadmap, the shared care record roadmap from NHS England, is something that we'll refer to throughout the series of webinars and into the customer webinar. It's driving a lot of the product work that we're doing at the moment, and it's also relevant to this call, and we'll see over the series of webinars how the different elements of this build into the picture of what can be delivered. So most of you will have seen this, of course, and there are different elements in here. So integration of care plans, local government, building in social care. And very often when we look at this, we can think, well, we need to actually, build in solutions around social care providers, or, what does this actually mean? Very often it's about saying, let's give access to the information for people in social care providers. Phase 1, phase 2, phase 3. Doesn't actually give a lot of detail at this point what's required, but what we're trying to show here is how we build up a picture of giving the right level of access to people across these different organizations. But if you look at something like care plans, for example, somebody in the care home and in social care setting might need to see a care plan, and we'll be doing more on that in the next webinar setting. Might they also be writing into the care plan from that setting? But it all starts with giving people access. So this is something that we'll refer to over and over again as we go through the different webinars. Katie mentioned PRSB, and Ben, who's one of the panelists on the call for questions later, has been doing a lot of work with PRSB. The core information standard is something that we are adopting into the shared care record. It drives how we display data, how you access the data, but PRSB also provides the framework for what different parts of health and social care, what information they need to be seeing, what should be mandatory and what is optional. So it drives the use cases that we have and will dictate some of the RBAC and use cases that we'll talk about later. The other element within this is PODAC, so digital community pharmacy, optometry, dentistry, ambulance and community care program. And there's details on the NHS digital website of a webinar that's being hosted tomorrow about how this is being adopted and rolled out. But again, this just starts to touch on all of those points that all of the interactions and the people that need to actually see the record. But it's a fantastic start, and it lays down a foundation for what people should be looking at in a safe and, from our point of view, a consistent way, because it's important that we're able to roll this out in a consistent fashion. So I'm just going to touch on a few examples here of areas where this is being used. So from a care home point of view, Connecting Care started rolling out to care homes. Chai are rolling out to care homes as well. Across the UK, you've got the numbers there of the number of care homes, 17,500 care homes, nearly 490,000 people residing in a care home at the moment. And people live in care homes. It's very transitory as they move between them, and you tend to have people with high comorbidities and high dependency on health and social care as well. So it's an absolutely vital part of our health and social care ecosystem. And throughout the pandemic, that really became apparent. From a care home point of view, I wanted to pick out this one particular sentence here. It's essential to establish secure information sharing arrangements between care homes, general practice and other community providers and acute settings. And we will all know, as I've just shared, a first or second-hand example where somebody working in a care home should have access to some core information, and that core information has been laid out by PRSB and the core information standard for what should be accessible within the care home. The initial projects rolling out to care homes is going very well, and we can address two different examples there. We'll talk about this later in the challenges of how technically they've addressed this. Okay, so that's a quote there from Forest Care, which I think is in the Connecting Care region. We're able to get blood results and other diagnostic results, speed up residents' interventions. So it's good for staff, and it's also good for the patients, of course, as well. This was some work, this came from Connecting Care, and there was a whole story behind this of how this particular patient, as an example, goes through a journey in and out of the care home into hospital and back again. But the key here is that the lady comments that the care plan that is relevant to her can be seen right across all those different organizations. The care staff in the care home can see the care plan in connecting care, but they're also able to print it out and physically give it to her as well, so she has that security. And what the example I was giving you earlier, when I was relaying this and talking about this, they said, oh yes, we have the care plans, they're printed out and they're in a file somewhere. So, you know, it's a very typical example that we see. But here, this lady's able to have that reassurance of the paper printed out and given to her, but the actual master record and the care plan is available in Connecting Care, and as throughout her journey was seen by multiple people. So community pharmacy, to move off care homes, community pharmacy being rolled out at Dorset. And these are some of the benefits that we see in community pharmacy. Has an item actually been prescribed? Is the patient taking the medication? The GP recommends one particular thing and something else might be more relevant. Minimize patient risk, optimize patient experience, and improve staff satisfaction. And again, it comes back to those buggeration factors of dealing with people at the counter, but then dealing with phone calls, updating systems, not having access to the information. And particularly in a medication setting, people can't always remember what the medications are that they're actually on are. And, you know, within the meds as well, again, people will move around. There'll be a lot of meds dispensed from an acute setting, a GP setting, and it's important we get one picture of all of those. And the community pharmacists can play a vital role in that. Elsewhere in the world, we certainly see that community pharmacists play more of an active role in things like medicines reconciliation, using some of the other solutions that we have. But I won't go into a medications pitch. Okay. So again, a couple of things there, the quotes from community pharmacists using it from Dorset and Hampshire. Most useful thing is to get answers to queries and can sort out the problem. And again, it's about staff satisfaction there. With the blister pack and the information there, it's about knowing, you know, what's been dispensed and what's actually being used by the patient. It's all about information, and it's about the buggeration factors, as I keep coming back to. If the systems can improve life for the staff, staff will pass on those benefits to the patients and deliver better care. So in terms of optometry, and there are 14,000 optometrists, including 6,000 dispensing opticians in the UK, and NHS Digital recommends access to the GP data for these benefits here. This wasn't an area that sprung out to me until I started doing the research for this. And when I looked at the example of optometry from Northern Ireland here, I had to Google, we're going to see a gentleman in a moment on a video, and hopefully that all plays okay, speaking about how they use the system. And I was expecting to see a specialist eye clinic or something like that, but no, this is a small independent opticians in Belfast using the system. And it just shows how there are so many interactions that it's important that people can have access. And for 90% of the time, it may not be that important. It may be a cursory look, but there will be always those cases when there's an investigation to find out, and how we then help them do that. So if I just go to the next slide, I'm just going to, hopefully this will play. The only person I can see on video is Katie. So if you can hear the sound, Katie, just nod. If not, then start waving furiously. Supports me and the fact that I can follow up. You can't hear that, no?
Patient's journey along the hospital eye service pathway. So from when I refer them, I can see what has happened at the hospital. I can see what condition they've been diagnosed with. I can see what procedures they're going through, what procedures they've had at the hospital. It allows me to give better advice to the person, to the patient that's in front of me. The NAECR is a very easy system to use. It takes 2 or 3 seconds to log onto the system. The information that you find is very well laid out, and there's only a couple of buttons to click. It's a very secure system, so it's very safe for me to use with regards to the patient. I can use the system when the patient is in the chair beside me, so that it can be instantaneously information in front of me. Well, there's one particular patient that I can think of that has helped me with an IECR. This guy came in and his main complaint, the main thing that he could remember from the hospital eye service was that the ophthalmologist told him that he was losing power in his retina. I was instantaneously able to look that up in the system to find out he had a condition called rod cone dystrophy. I was able to give that person better advice, give him a prognosis of what his condition entails, to talk him through the repercussions of having that condition. He was under the assumption that that condition was manageable and would improve with glasses. Obviously, with something, a condition like rod cone dystrophy, you just manage it as best you can.
Okay, can you hear me back now? Yeah, perfect. So I'll just move on. So I really like that video, and it just shows again a particular example of probably 80% of patients coming through the optician is dealt with in a particular way, but every now and again there'll be something that presents that needs additional information. And this gentleman was able to demonstrate how just having that information made a difference to him. When he was talking about the Northern Ireland shared care record there, which is the same platform that you all have. So in terms of the challenges to achieve something like this, there will be a number of challenges. So information governance will always be right at the top of the agenda. Security, of course, is key. Roles-based access, licenses. Do we have licenses to roll this out to everybody? Do we have enough licenses for thousands of people? If we're then having all these different people logging in, there's the management of those accounts. There's a lot of people to train. How easy is the system? So there's a lot of these challenges for sure. The fundamental thing for me, though, is these questions. Does sharing data across health and social care have a positive impact upon citizen care? So that's the number one question. And I think people would probably say it's hard to argue with that. But the other question is, does access to the right information have a positive impact on the work undertaken for the work as well? So these buggeration factors I've talked about, more fundamental than that as well. So if the answer to those two questions is yes, then I think we have to look at the challenges as work that needs to happen to achieve the outcome that we're looking at. So I've tried to break these down, and this is the last slide before we go to Q&A, we can answer questions, is how do we address some of these things? So from a security point of view, when you break outside of the secure network and providing access via public internet, then there's a number of ways people have addressed this. So in Connecting Care, they're providing some VPN tunnels to the care homes that are using it. We've provided whitelisting previously to organizations. Both of those things need quite a bit of management as well. It's difficult to provide those on a sustainable footing when you really want to roll out beyond what might be an initial pilot. In Chai, they were our first customer to go live with multi-factor authentication, which you see in just about every walk of life now. When you want to buy something, you often get challenged when you're using a credit card, for example. But if you're buying things online, log into different websites, you'll be asked to enter an additional code for that one-time use only. So in the case of the multi-factor authentication that we provide and they're using in Chai, I believe it's Google Authenticator, which gives you a code which challenges you when you log in. Now that's only relevant when you're using a username and password to log in. It doesn't challenge if you're an SSO user. So they're the different aspects broadly around security. From an IG point of view, and there's a useful several 100-page document there if you want to have a look at it in terms of IG. But IG has a whole load of, it's there to protect sharing of information, not restrict sharing of information. We talked earlier about the PRSB standards and how those standards are suggesting what data needs to be shared in different care settings, so we can align our roles-based access around those standards so that there's some assurity of that. The data sharing agreements obviously need to govern this as well, but I think it's also important, not from a national guidance and governance point of view, but there is local governance around this, but really importantly the sponsorship to say this is work that has to happen because the objective is to deliver better care, a better equity of care, and the only way we're going to do that is by sharing access to the data. So these are things that have to happen, but that has to be driven from a leadership level to say we need to achieve those outcomes. Otherwise, we've created another silo of information. From an adoption point of view, I think, again, just to pick up on PRSB, that across the different settings, there'll be an expectation of what information they need to see and want to see, and that will be common across different systems. So there will be some level of comfort that's the type of information that they want to see. From a single sign-on and an RBAC point of view, it also means that when we're suggesting rolling out to whether it's care homes or dentists or connected care, we're doing some work with the prison service or whatever it might be, we can start having specific views and dashboards that are relevant to those organizations, because when you log into the system you need to see the most information, the most useful information to you. So that will be based on how you log in, what you see, and making it as easy as possible. I mentioned licensing as well. So, licensing shouldn't be a barrier to logging in and looking at the information. So if there is any restrictions on license numbers, then, talk to us about that, because that's, that's not the business that we're in. We want people to access the information and start using the information. So licensing should not be the issue. There are some clear security questions that we need to answer, and there are some questions around sharing data, data sharing agreements, information governance, and all of those things. Those are tasks that need to happen. If the fundamental answer to the questions of, is this a good idea? Is it going to improve the life of our citizens? And is it going to improve the life of our staff? If the answer to those is yes, then fundamentally we can work through those to make sure we deliver access to the information. I think I'm probably ahead of time with that, or just shortly, because I think we allowed 45 minutes. So that's about half an hour. I can't see the chat, so I'll hand back to Katie, who can pose any questions which we can answer now. And if there's any additional questions and we don't get around to it, then we'll follow up afterwards.
Thank you, Brian. I think it was so interesting to hear of the benefits that some of our customers are finding through that shared care record expansion in certain areas, and also some of those technical enablers you discussed around MFA, role-based access. So the challenge is surmountable. That's the good news. We've not had any questions come through in the chat yet, so those on the call, please feel free to put a question in the chat or raise your hand and we can take you off mute. But whilst we're seeing if any questions come through, Ben has put in the chat some details of how you can register for 2 webinars that the NHS are running tomorrow around expanding access to community health and community pharmacy. So if this is a topic of interest to you, which it must be because you're here, do register for those webinars also.
Just while we're waiting if there's any questions, one of the slides which I left out because I didn't think I'd have time to go through it was how down in Bristol, they're using it with the prison service as well. And again, it's an area that I don't have a lot of experience, or let's be honest, any experience. So it wasn't something that sprung to mind. But it was around how prisoners, when they're discharged, that the discharge summary of any care that they've received whilst in prison is sent to their GP. But of course, you don't necessarily get sent to prison where your GP is, when there could be hundreds of miles between the two. So when you're then discharged from the prison and released from prison, it's access to those local services where you are, which perhaps might be important, because you might not immediately go back to where you're registered with your GP. And of course, prisoners will often suffer from mental health problems, anxiety, etc., but also may have gone into prison with drug and alcohol dependencies, and those and their body will be severely weakened, the tolerances level, whilst they've been in prison. So very often when they come out of prison, a small amount of drug or alcohol will have a bigger effect upon them. Their record is simply not known to any local services that are being delivered in the area, because the discharge summary went hundreds of miles away to their GP. So they're using Connecting Care in that service to actually help those prisoners being released, which I think is a really interesting example of how it's being used, and just thinking about how that access to information can help a certain population of people, which is fascinating.
Well, Brian, we've not had any questions come through on the chat or any raised hands.
No problem.
So if there's nothing further to add, I guess we'll give you 15 minutes back in your days, and thank you very much for joining. You get in touch if you have any further questions.
Thank you very much.
Thank you.